Uh, Wish you all a very, very good morning or good afternoon, depending upon what time of the day or evening you're listening to this. The topic that we will cover today is a very, very important topic from a clinical perspective. It's something that we as clinicians will observe on a day-to-day basis with majority of the patients who are going to walk into our practices. Okay. We have to understand that a lot of patients, irrespective at sometimes on irrespective of the amount of age gap what they have, a lot of patients for whom we will see will have one or the other kind of a medical condition. Okay, it can be a simple allergy to a certain drug to a much more severe forms of medical compromise situation. So managing or understanding these medical conditions and obviously learning to manage these patients when they come to you for your periodontal interventions or any general dental interventions is very, very important. Okay, so today we shall learn about periodontal management of medically compromised patients, what are the different types of periodontal conditions, what we would encounter in them, and then especially we learn about each and every medical condition, and then we'll start planning on how we intervene and what medications, precautions, etc. we take when these patients walk into our practices. Okay, so what's very, very important is before we start intervention, these are the very, very important steps what we'll have to cover. Very important is the collection of information. Knowing your patient's medical history is absolute importance, followed by the physical examination, laboratory tests, and various special tests that are required. In the college right now, as students, you are very fortunate that we have a general medical department which takes care of this even before the patient comes to you. On the other hand, that's not the situation in individualized practices or group practices. So there, you as a dentist, as a clinician, you will have to take a care whether the patient has to be referred back to a physician, take his or her consult, and then proceed with your dental interventions. Okay. There are times where you as a dentist itself will be in a position to identify some of the medical issues what the patient may have, and then refer the patient for the first medical consultation for him or for herself. Obviously, there are certain laboratory tests which we on a routine basis prescribe to our patients so that we are very sure that they do not carry any issues when they're undergoing dental interventions. There are certain special tests. If required, we will get those done, and that's very, very important. Apart from that, obviously, is we will do a systematic evaluation of information. So it means we evaluate the patient's dental part and we'll evaluate the patient's medical part. And once both of them are evaluated, then we will take them for treatments or interventions. Also, if required, we will add additional investigations so the patient complete the diagnosis, and only then, once we are very sure that this patient's medical condition is not going to adversely affect him or her when they are undergoing dental treatments, only then we'll start doing definitive treatment planning and interventions. It's very, very important to understand that any untoward incident happening to the patient when they are under your care, they become your responsibility. So when we look at that, you do not want to be putting a patient into a medical risk or a health risk or a life risk. So that's why it's very, very important. The importance just cannot be understated on knowing what are the various medical conditions that can affect our dental practice and primarily the periodontal practice. So this is what you know. Most of the patients who come to us primarily come to a dentist for caries, periodontal disease, or trauma. Okay, but then what's very important from our point of view is irrespective of this, you need to know the patient's medical status. So what are the various medical conditions that we are looking at in our patients? The various medical conditions that we are looking at in our patients are these: age, cardiac history, endocrinological diseases, hematologic, bone diseases, central nervous system disorders, respiratory, patients on prosthetic joints or any other kind of organ replacements, and patients who have cancer or history of cancer. Let's look at age. Per se, there is no age bar to which patient can come to you for periodontal care. We see children with small or minor gingivitis. And on the other hand, we also see someone who's even 90, 95 years of age looking to save his teeth or undergoing certain kind of interventions on his or her teeth. So we are going to see, as clinicians, patients across all age groups coming into our practices. What's important? Age, the number of the age is important because it helps in making a certain type of diagnosis for us. And secondly, what's very important, irrespective of the age, we're looking at fitness. We can have a 20-year-old boy who is absolutely unfit, and we can have an 80-year-old man who is absolutely fit. So it doesn't make any difference on what age it is. What we look at fitness is whether they're able to withstand the clinical procedures that are supposed to be done, and also whether the age of the patient is influencing the disease process or the interventions to the disease. So age per se is no barrier to whom we will see in our clinical states. Apart from that, very, very important point to be concerned when we're looking at clinical practice is the psychological state of the patient. And at times, this is directly related to the age. Younger patients who are at a younger age group, usually have a highly demanding perspective, especially when it comes to their aesthetics and functionality. Okay, they want to look good, they want good teeth, they do not want to have gaps between their teeth. So someone who's got what we call as aggressive forms of periodontal disease, they actually may end up coming to your clinic at the age of 18 or 20 with telling, doctor, I didn't have spaces between my teeth. Now suddenly in the last 3 or 4 months, I see that a lot of gaps have opened up between the teeth. It is actually telling you the diagnosis even before you do a clinical intervention or observe these patients. So that's why knowing the psychological state of your patient is very important. Why it's also important is to see whether they can comply with your dental instructions. What does it mean? Someone who's psychologically stable and who would understand the instructions that you give them, pre and post-op instructions, they will follow them diligently, and that will automatically determine how wonderful will be the outcome. On the other hand, we're going to have patients who are very callous, who do not care for the instruction. They are just primarily concerned about having their primary concern or the actual complaint sorted out. The minute it's sorted out, they are not going to come back to you for further intervention. So they're not able to follow the instructions. And then what happens one fine day when the infection or the condition goes bad, they'll come and blame you directly. Doctor, you did not tell me about this. So what's important from our point of view as clinicians is, age-wise, is the psychological state of the patient that we have to evaluate. Also, very importantly, though the younger age group is demanding when it comes to aesthetics, the elderly age group are primarily concerned about how comfortably they're able to eat and how comfortable it is for them to maintain their dentition. You don't want to give them complex instructions on how to clean those teeth and all. They're probably not in a great situation to follow those instructions. So it's important that when you look at age of a patient, number one, there's no age bar to which patient can be treated for periodontal diseases, irrespective of the age bar. Fitness, they all have to be fit. And then very importantly, understand the psychological state. Also, the age is important when we start looking at our patients undergoing certain kind of interventions. For example, if someone has got deep pockets, angular bone defects, okay, and then they've got certain kind of a bone loss or gingival recession at an younger age group, then they are candidates in whom I would recommend to undergo a GTR therapy or bone graft, etc. Much higher end treatments, much more complicated treatments, because they can withstand those treatments. On the other hand, if I have an elderly man who's probably like 70, 75, then who've got some bone defects, some recession, then I would say we will do a non-surgical intervention and then we will maintain those teeth. Let there be a recession, but as long as we're able to maintain those teeth well, then that would be my intervention. So the kind of interventions that we do also will be determined by the kind of age of the patient. So if I have a 3.6 and 3.7 in a patient with an angular bone defect and certain recession, who's 25-year-old or a 30-year-old, even a 40-year-old, I would go ahead and do what we call entire bone graft, regenerative therapy, etc. On the other hand, if it is a 70-year-old patient, then I would just say we'll do a nice round of non-surgical therapy. Then we will avoid invasive procedures. But however, what we will do is we will keep you on a much more frequent recall visit or supportive care so that we can monitor the patient more frequently. So you determine your treatment as per the age of a particular patient. Age is also related to how easily a patient can commute to your practice. Okay, so if I have an younger patient, then it's very easy for me to call them more frequently and do further interventions. On the other hand, if they're elderly, they're not independent, they're dependent, because it means someone has to drive them to your clinic, drive them back to your clinic, and surrounding the situations that how comfortable it is for them to come and go from your clinic. In those situations, what's going to happen is you would rather have the number of visits which are minimized. So you want to see them less frequently, but you want to do a lot of treatments in that particular short duration of time. So age, when it comes, there are more than the direct influences. It is the lateral issues that are playing a role in this clinical condition. Next, and the most important question which we ask every patient who come to our clinic, okay, or into the dental wing, is that what is the allergic components for you? What are the various allergic components in you, or what you don't tolerate? The most common thing what we have to ask, the first and foremost question is, are you allergic to certain medications? Because we as dentists would prescribe a lot of medication. And so if we have patients, someone who says, doctor, I'm atopic to certain drugs, or I'm allergic to certain drugs, then that's the first thing you would make a list out and write it down in red on the top of your case paper. So you know that as soon as this patient comes, you see that red color thing and say, oh, okay, I'm not going to be prescribing these medications for these patients. The most common medications for which our patients are going to have allergy is penicillins, cephalosporins, and very rarely macrolide. Someone who's allergic to penicillin will usually have a reaction to cephalosporins as well as macrolide. So that's one thing you need to look. Sulfur drugs, though nowadays hardly anyone prescribes sulfur drugs, you need to keep a list of that. Someone says, doctor, I'm allergic to sulfur drugs. Especially these are patients who probably had some kind of skin disorder, because sulfur drugs are very commonly used in skin disorders. So they used and they have done unwanted reaction. So they would tell you directly, doctor, I am allergic to sulfur drugs. One of the important things that we have to look forward, and very, very, very important from a clinical perspective, is the contents of a local anesthetic bottle. So when you open up your local anesthetic bottle, you'll always see there's something called a preservative and there's something called a reducing agent. Okay. A lot of patients have, and an antifungal. Okay. A lot of patients have allergy to what we call the methyl paraben, which is a preservative in your local anesthetic bottle. So we have to ask the patient if you've undergone an extraction before and how eventful or uneventful it was. If they usually say, doctor, I didn't have any issues with that problem, then I think we are good enough to go ahead. But what's important is you make it a point to ask. You make a point to ask whether you are allergic to any local anesthetic. Because if that's the situation, then I would rather take the patient into general anesthesia and then operate on this particular case. One of the important things which we have to ask allergy is latex. Okay, a lot of people will tell you that they're allergic or not allergic to latex. It's actually not the latex. It's primarily due to the glove powder or the chalk. So every time you don on your gloves, you will see that there's a white color residue when you deglove. And this white color residue is nothing but chalk. So at times, some of the patients are allergic to this. So you need to be taking care. So what happens, you finish the treatment and then you see that the entire lip, cheek, as well as the tongue, etc., is all red, because every area where you touch with your glove, the patient's got an allergic reaction. Next, the most important clinical condition that we will be dealing in our patients is the cardiac history. Okay, the cardiac history is very vast. Let's begin with the most common one, and that is hypertension. Most of the people who walk into our clinics who are probably about 35 or 40 years of age will tell you that, doctor, I am hypertensive. Okay, very, very common. It's probably more common than diabetes. Okay, and why is it so important? Hypertension, because hypertension will determine how you intervene your patient. Okay, and also various medications that these people take. So when I'm looking at a patient who says, doctor, I'm hypertensive, I'm first looking at what are the values of his blood pressure. Okay, so if I'm planning a patient for a surgical procedure, then I don't want his or her blood pressure to be more than 140/90, or that's the maximum would be 150/95. If anyone is clocking more than this, then I would post the patient after intervention. So my limits for treating a patient with hypertension is either between 120/80 to 150/95. Anything more than that is absolutely no. Also, on the other side, there is a hypotension. So if someone is below 75, if their what you call the diastolic is below 70 rather, then I would not take them, because they can undergo into what you call a hypotonic shock. Apart from hypertension, the values, what's important for us to remember is what are the various medications these people are going to take. The most common medications that majority of the cardiologists prescribe these patients are calcium channel blockers and diuretics. And we know for sure that patients who are using calcium channel blockers, okay, they also have what we call as the gingival enlargement. Harun, Heli. Harun, Heli. Hello? Okay. Yeah. So the next thing, drug, what we have to be concerned about when we're treating patients with hypertension. When we're treating patients with hypertension is is diuretics. Okay, diuretics are those drugs which are given to patients for reducing hypertension, and they basically reduce the amount of blood fluid in your body by making someone go to the toilet more often. So if you're planning a long surgical procedure for these patients, a long procedure for the patient, then you make sure that they've visited the restrooms more frequently prior to starting the procedure, because you don't want to be taking the patient to surgery, and then in between the surgery, when everything is asepsis, everything is ready, the patient says, doctor, I need to use the restroom. So you don't want to be in that situation. So very, very important things is you check what medications your patients are taking. Calcium channel blockers, we all know that certain calcium channel blockers, especially drugs like nifedipine, amlodipine, etc., they cause gingival enlargements. And so if there is a patient who's taking this drug with a considerable amount of gingival enlargement, kindly request the physician who's seeing this patient to what we call as change the drug to a non-calcium channel blocker kind of a drug. Apart from that, there are certain situations which is very, very important, especially when you're treating hypertensive patients, is postural hypertension. For example, if I have a patient who's sleeping on the chair for more than 45 minutes to an hour during a long surgical case, etc., then if I take the patient to go back to the normal seating position, I upright the backrest of the chair, and the patient suddenly gets up, you will see that patients will tell, doctor, I'm suddenly feeling giddy. And this is primarily due to something called as postural hypotension. When they change posture from supine to suddenly getting up, they undergo, all the blood flow goes to the peripheries, and then patients start feeling giddy. So always important that when you're treating hypertensive patients, you take the chair back up slowly, ask the patient to put their feet down. So we call it as what we call a 5-minute protocol. So patient comes, the backrest comes up, wait for 5 minutes, put the feet down for 5 more minutes, and then they're ready to get up and go out of the chair. Very, very important finding. We have to be concerned at all points of time while treating hypertensive patients, irrespective of the BP, while we are doing the treatment, is what we call as bleeding. Hypertensive patients have a preponderance to bleed. That's primarily due to the excessive amount of pressure in the vessels. Though intraorally we do not have any major vessels, but yes, at times even a capillary bleed can cause a certain amount of discomfort. What happens is you discharge the patient goes back home and then says, doctor, there is some ooze continuously, it's not stopping. So it's very important that before you send these patients back home, you see that the bleeding is completely arrested. There's no actual bleeding. It's completely so. So once you finish the treatment, you make these patients sit for half an hour to 45 minutes in the waiting area, etc. Call them back again, check there's no bleeding, only then you discharge out these cases. Apart from that, yes, there is a certain drug you need to keep in your emergency kit for hypertensive patients. That would be a sublingual nitrodipine or a sublingual nitroglycerin. You need to keep them in your clinic. Always have some physician as your friend so who can come and see your patients. So as a treatment protocol in my particular practice, what we do and which I recommend everyone is keep an automated BP machine. So what happens before you start the treatment, take the measurement of the patient. Even if they've taken their medication, you can take the measurement, and with an automated machine, you need to check it minimum 3 times. Okay, take 3 values, make an average out of it and write it down. So you know what's the value of the patient before you started the procedure. And if you have longer procedure, then you can obviously re-record in between. Okay, so this will help you keep safe and very sure what you are doing. The next heart medical condition related to heart, what our patients can encounter or what we can encounter with our patients is what you call as angina or angina pectoris, basically kind of a chest pain. The best part of this condition is that patient knows that they have angina. They know, they're very sure of that. The worst part is frequency. They don't know the frequency. Okay, some patients are regular, some patients are irregular. So the worst part of angina is it's unpredictable. Okay, so what's very important for us to ask prior to starting treatment of these patients is, when was the last attack? Time since last angina attack will help us predict what is going to happen. If someone is having longer gaps between 2 attacks, then they are probably a much more safer patient than someone who has attacks more frequently. Okay, the best part again of this condition is self-medicated. Every patient who has angina pectoris would medicate themselves. Okay, they know what medication they have to take and what the treatment. Allow them to medicate themselves and give them a good amount of rest. So what I would recommend for everyone, if you have to manage a patient for periodontal treatment with angina, is you fix a comfortable appointment. What it means? The appointment means that you ask the patient to rest well overnight, ask them to take all their medications, have an excellent breakfast, and then come down the next day morning, probably by around 11 o'clock or 12 o'clock, so that they're well rested, well relaxed, and then when they come to your clinic, they're in a relaxed phase. The problem is if you try to schedule them a bit more early in the day, probably at around 9 o'clock in the morning, or much more later in the day, the stress would add on to it. Means if you call them at 9 o'clock, they're stressing themselves that, oh God, I have to go at 9 o'clock, so I need to get up early. So they may not sleep well, and that can lead to a problem. Secondly, you call them much later in the day, probably evening at around 5:30 or 6 o'clock. The issue is they would have worked through the day, and then there would be a bit of a stress that would have accumulated, and then that might lead to a problem. So the best thing is to call them on what we call as a midday, early midday kind of a situation, 11 or 12 o'clock in the day. So you fix a very comfortable appointment for them. Apart from that, obviously, you'll have to do a physician consult, and please do not use LA without adrenaline. The LA should contain adrenaline, and it acts as a preventive mechanism for these cases. Next. The next and the most common heart condition that we would encounter in our practices would be what we call as myocardial infarctions. The best part is it's very unlikely that a patient is going to have MI in your clinic. Okay, in all likelihood, they would give you a history of angina, and then if someone says, doctor, I have a history of angina, then you would directly refer them off to a physician. They would get all their treatments done and then come back. What's important for us to treating patients with MI? The duration from the last MI to their clinical interventions, dental interventions, should be a period of 6 months. So you will not see anyone in your clinic who says, doctor, I had an MI in probably, if this is August, you will not see someone who says, doctor, I had an MI in May. No, they need to be having their MI probably only in the month of Jan or Feb. So there has to be a 6-month gap between their MI and then their dental interventions, nothing before that. Very importantly, patients who have MI are as good as non-MI, in the sense that because they know that they had MI, they would have either undergone angioplasty or a stent placement, what we call them, or they would have undergone a bypass. So either ways, they're as good as normal patients. Check their hypertension levels, check their medications, what all they're taking, and then they're good to go. You don't need to give any antibiotic prophylaxis, but yes, what's important to give is, because these patients and even patients who are on angina, they would be on what we call as anti-clotting agents. They would be taking medications to prevent blood clot in their vessels. So that's the reason why you need to check their medication history. So most of them would be taking an aspirin or a clopidogrel. So if you have these patients taking these drugs, then you need to get the bleeding time, clotting time, INR, and then their what you call PTT. Okay, so get these checks done. See if they're within the normal range, then you're good to go and treat these patients. But yes, take a proper history and literally ask them to get their medical files with them to you. The next medical condition, heart, related to heart, that's going to influence us would be what we call as the valvular disease. The best part again is patient knows that they have a heart valve problem. They all know that either they're damaged or repaired. Okay, irrespective of whatever it is, the only thing that we have to do is give them a nice pre-medication, amoxicillin 2 grams 1 hour prior, azithromycin 2 grams 1 hour prior. And then in case they have a dental infection, then you would have already started them on an antibiotic. So the antibiotic coverage would already be our starting on these patients even before you do anything. So that's the best thing that you can see in these patients. The next set of medical conditions, which we'll have to be absolutely concerned when they come to our clinics for treatments, are hematologic disorders. Hematologic disorders are something to be very scared about. The reason to be scared is they can be life risk. Okay, so what are we looking at? We're looking at the red blood cell disorders, which includes anemias. We're looking at white blood cell disorders, which include directly related to infection and immunity. And then we're looking at platelet and clotting system disorders, which include bleeding and inability to stop the bleeding. Anemias, okay, very common. In a country like India, probably 60% of the population is anemic. Okay, and what do we mean by that? Yes, most of them have a hemoglobin level or a percentage which is much lesser than 10. Okay, so what you do is a standard operating protocol for every patient that you intend to undergo or to take them for a certain procedure. You get the normal hemoglobin level checked. Okay, if it is above 10, then yes, you take them for procedures. If no, then you send them for a medication. In all likelihood, I probably, as on it, must have identified around 50 patients with anemia coming to dental intervention. The minute you ask them to open their mouth, you'll see that the tongue is bald, there are no papillae there, it's more paler. And then you ask the patient, how good are they doing? They'll usually tell you, doctor, especially if your clinic is on the first or second floor, if they're taken the stair, they'll start doing this. And that's because the amount of hemoglobin in the body is so less that the amount of oxygen that is required for the heart is far lesser. So that's the reason why we as dentists probably were one of the first set of people who would identify anemia in our patients. So you do what you call a CTN test, check for conjunctiva, tongue, and then nail for pallor, and you are the ones who will diagnose this case. If that's a case, send them to a physician to get things done, and then this one. At no cost, you will intervene, because if you treat a patient with anemia, if the blood supply to the area, even for example, you have to remove a tooth. If you extract a tooth, patient is anemic, then what's going to happen? The site will not heal. The blood clot will not fill the socket, site will not heal, and patient is going to have a secondary infection. So that's not very good. So very important thing is, if you identify anyone or you suspect anyone with anemia, you directly refer them to a physician. Next, again, leukemias. The most dangerous clinical situation, and the worst part is we would be, as dentists, the first people, and especially as perio, the first set of people to identify someone who's got leukemia. And the reason is that gingival bleeding is one of the most pathognomic and most common sign for which the patient would come to a dentist who has leukemia. So you ask the patient to sit on the chair and you take a history. Why may I know Mr. or Mrs. Wife come here? They'll tell, doctor, I'm having bleeding from my gums. As soon as I get up in the morning, I'll see that my pillow is red. I put a brush in my mouth and it starts bleeding. At times when I just even rinse with water, it starts bleeding. This is a very dangerous situation to hear. Okay, you don't even do an examination in these situations. You don't use a probe. So what you do, ask the patient to sit, take 2 mouth mirrors, retract and check. What you'll observe, you will in all likelihood observe the gingiva is badly swollen, extremely enlarged, and you will already see some clots, blood clots on the gingival margin. It means that this patient is not a normal gingival enlargement. In all likelihood, it's leukemia. So I have probably identified around 4 patients who had leukemia in my practice. So in all likelihood, I would say that you as a dentist would be one of the first patients to identify leukemic patients. So obviously clinical intervention wise, absolutely no interventions. Send the patient out to a physician. Next, anything related to platelets and clotting systems. So patients can have thrombocytopenias, they can have purpuras, or they can have what we call as any other clotting disorders like factor 8 deficiency, factor 9 deficiency, etc. All these patients are ones who will not be treated, upfront. So they may have pockets, they may have bone loss, they're ready to undergo the treatment, but you will not treat them for the very simple reason that you don't know whether the blood will stop, whether the patient will stop bleeding if you made an incision or extracted a tooth or even done some small scaling. So what you do, if these are the situations, the best thing is to send them to a physician. And once the physician gives a green signal, even then I would always treat these patients in a hospital setup. So I would admit them to hospital under an anesthetist, under a hematologist, etc., and then start treating. I would not treat them as an independent in a freestanding or an independent dental practice. Okay, one of the conditions that we can encounter, blood disorders in our practices, would be a thalassemia. Thalassemia has two types. One is major and minor. Major are those patients who undergo continual blood transfusions, and they're not very good patients to be treated unless and until they do not have any infections, etc. On the other hand, patients with minor thalassemia minor, as good as normal patients, and you can start treating them as good as you treat a systemically healthy patient. The next medical conditions we have to be absolutely concerned from a periodontal perspective is patients with bone disorders. Okay, one sec. Okay. Yes. So one of the most important medical conditions that we'll have to be very careful when we look at treating patients with periodontal disease is bone disorders. There are three main disorders that includes osteoporosis, vitamin D deficiency, and then there's parathyroid hormone disorders. Okay, upfront, the most important one from our perspective is osteoporosis. Patients with osteoporosis have higher preponderance to developing periodontal disease. Okay, but it happens at a much later part of their life. Okay, so someone who's and it's very common in what we call as postmenopausal women. If there's a lady who's attained menopause at the age of around 50 years, then for her to have osteoporosis induced periodontal disease would be much later in her age group, probably when she's probably 75. But however, the response of these patients to undergoing interventions is much more poor. So you need to be very careful. So what I would recommend, if someone says, doctor, I have postmenopausal, I've been diagnosed with osteoporosis, then you put these patients on non-surgical therapy and call them more frequently, okay, so that they do not develop any signs of periodontal disease, etc. Okay, put them on a good hygiene, good oral hygiene protocol, and more frequent visits so that they have inflammation. If it is there, then it will be very, very minimal. Okay, and you reinforce oral hygiene so that they do not catch any periodontal disease, because in case these patients develop periodontal disease or bone loss, then it's very difficult to treat them and it's very difficult to grow or regenerate the periodontal tissues in these patients. So that's something we have to be very careful. Secondly, when you look at doing extractions or implants, etc., in these patients, then you have to be doubly careful that they're taking those medications for osteoporosis, that is primarily includes fortified calcium, and then they are not on certain drugs called as what we call as bisphosphonates. There are a lot of patients who have what we call as bisphosphonate. Bisphosphonates are a group of drugs given by orthopedicians rather, to their patients who have osteoporosis. What these bisphosphonates do, this class of drugs inhibits osteoclastic activity. Okay, and because the osteoclastic activity is inhibited, the bone is not resorbed. So that's how they prevent fracture of long bones in these patients. But however, because osteoclastic activity is not happening, every time you extract a tooth, the dead and damaged bone that you create due to the extractive forces does not undergo healing, because unless the osteoclast comes and remove the dead and the injured bone, new bone cannot be formed. And that's why a lot of patients who have osteoporosis, in case you do a periodontal surgery or a bone graft, etc., they will not heal well, but they'll actually end up having a secondary infection. Okay, so we call it as bisphosphonate induced osteonecrosis of the jaw, or otherwise we also call it as osteochemonecrosis, chemically induced. Chemical is the bisphosphonate drug. Oh, so that's why it's very important for us to understand that if I have a patient who says, doctor, I have osteoporosis, then the first and foremost I'll ask them is whether they're on bisphosphonates. If they're on bisphosphonates, then the next thing you do is you ask them to stop the drug. Okay, in consultation with the in consultation with the orthopedician. You don't stop the drug, but you refer it back to the orthopedician or the physician who's put the patient on the drug. The drug has to be stopped. You wait for the next 3 months, not before 3 months. You wait for 3 months and then you start the intervention. Secondly, some of them would be, especially people who undergone overectomies, etc., due to some cancer, etc., they would be on some kind of hormone replacement therapy. So you need to check with that. Okay, one of the easiest ways to evaluate how good the bone is, even in osteoporotic individuals, is you check for what we call as a bone scan or Hounsfield units. If the Hounsfield units are probably more than around 300, then I think the bone is good enough to undergo a procedure. The next is vitamin D deficiency. Vitamin D deficiency is far more common than what we think it is. Okay, even in a tropical country like India, because most of us are sitting in these halls, AC rooms, etc., we are not exposed to the sun as much as we used to be. So what we are seeing is there is a high amount of vitamin D deficiency. So you need to get the vitamin D levels. You don't want to get the levels done. You ask a patient to walk on the terrace early in the morning from 6 to 9 and for a month and then come back to you. Or option 2 is you can ask the patient to take vitamin D tablets, something like a calcium max fortified vitamin D with calcium, and then come to your clinics probably after 4 doses of the drug and they are good enough to go. Next, digestive system disorders which influence periodontal disease or their interventions are liver disorders. Okay, liver disorders, though liver disorders do not cause any periodontal disease, but they influence interventions or treatments. Okay, so someone, especially chronic alcoholics, patients with some idiopathic liver disorders, etc., they have a problem. The problem is that there are clotting factors which are manufactured in the liver. That's all the vitamin K dependent, what you call clotting factors. Now, if someone says, doctor, I have history of jaundice, I undergo blood transfusion, or I take a certain amount of alcohol every day, and you can literally see in their bloodshot eyes, etc. Okay, these patients are not very good patients for interventions unless and until they are cleared by their medical physician. Okay, so these are those patients who are going to have clotting issues. The minute you probe, the blood will just ooze out from the area. So you are better off taking a very clear-cut medical history, and then only you start these patients on interventions. The next are what we call as patients with CNS disorders. Okay, what do we mean by CNS disorders? Patients, the most common CNS condition that I, as a clinician, am concerned is what we call as, okay, so next are the central nervous system disorders. Central nervous system disorders, though, do not cause any issues to us as the periodontal disease process, but yes, they have again an influence on how we treat these patients. The most common condition what we are looking at is what we call as the seizure. Okay, I would not go into much details about what type of epilepsy or anything is there. What I'm concerned as a periodontist, as a clinician, is whether my patient is going to have a seizure on the dental chair when I'm intervening in these patients. Okay, so what's important for me is check. What am I checking? I'm checking whether the patient has taken or is taking all the medications he or she is prescribed. I'm going to check when was the last seizure happened. If someone is having a long gap between 2 seizures, then they are more safer patients, because the likelihood of them having an attack is much lesser. Secondly, they all carry their medication, so they're taking their medications. What you can actually do as a dentist to prevent an attack on the chair is, number 1, you ask the patient to double dose themselves. So if they're taking 1 tablet a day, you can even ask them to take 2 tablets one day prior to coming to your clinic, or if they're taking tablet in the morning after breakfast, so you ask them to take, instead of one, take two. So what it does, it reduces their anxiety. It also reduces the chance of having a seizure attack when they're on the dental chair. So that's the best thing and the most simplest thing that you can do, and you can go ahead and do whatever interventions you want. But be careful that you keep the interventions smaller. See that it's done in a more soothing environment, because what triggers a seizure is not known. We don't know what can create an epileptic attack. So very important is that part. Okay, so as long as you're good with that part, I think you can go. Yeah. So when we're looking at these cases, the advantage of people with epilepsy or this one is they carry their medication. So double dose them and always schedule them again at a very comfortable appointment. Keep the environment very soothing. Avoid doing jerky movements, because you don't know what triggers an epileptic attack. And that's very important. Take what we call the safe precautions when we're treating these cases. The next condition which we have to be very concerned nowadays of late are what we call as patients who undergone kidney transplant or who are on dialysis. Okay, as we all know, certain drugs get metabolized in the liver and certain gets metabolized in the kidney. Now there are a lot of medications are kidney toxics or renal toxics, and for that reason we need to avoid a lot of drugs, especially NSAIDs. Anyone who says he's got a kidney disorder or renal disorder, for them NSAIDs are completely out of the box. You're not prescribing them any NSAIDs whatsoever. So if you have to give them a painkiller, then it will always be what we call as a tramadol. The drug of choice for these people would be a tramadol rather than any other form of NSAIDs. So apart from that, they're good enough to undergo any intervention, so they should be fine. Next. Respiratory system disorder. So the issue with respiratory system disorder is very similar to what we are dealing now with COVID. Okay, what's important we have to understand with respiratory is it's not about the patient, it's about the operator and his staff or her staff. So very, very important for us to remember is that we need to see that there is absolute amount of self-protection. So taking care of all your entire PPE is very important. Ask the patient for histories of tuberculosis, pneumonia, etc. And then you should be good to go about treating these cases. But yes, asthma is one condition you have to be careful, so that when you're treating patients with asthma, you have very high, good quality suction. You don't want to be pooling saliva or aerosols when you are treating. So if you're doing an ultrasonic scaling and there's a lot of splatter, it can create a choking response in these patients who have asthma. So for that reason, you tell that these patients to take their asthma inhaler, and then you see that you use a very strong suction so that all the aerosols are completely sucked out, and that's how you keep the area safe in these patients for these cases, and you can finish whatever surgery you want to do. Apart from that, you also have a lot of medical conditions such as chemotherapy and radiotherapy. Very important is you do not do any elective procedures unless and until they're completely cleared out of their cancer and then they're ready and fit enough to undergo the procedure. You can go ahead and do the whatever procedures you want to do. There's no hard and fast rule that you should not do. You can do everything from an implant to perisurgery, graft, etc. But there's nothing against it not doing. Very, very important, and that's why I kept this for the last, is what we call as endocrinological disorders. Very important, very commonly seen in our patients. Okay, diabetes is now literally affecting probably 50% of the population. Majority of the population above 40 is diabetic. Apart from that, there are a huge number of patients who have thyroid-related disorders. Okay, so what's important in diabetic individuals? If we stop treating patients with diabetes, then we would hardly be making any money in our practices, because every second person who walks into a clinic is diabetic. Okay, so what's important when we're looking at diabetic patients? They're not a contraindication. Diabetic patients are as good an indication to undergo any dental interventions, whether it's periodontal or non-periodontal. But what's important for us to understand is what type of diabetic are they, whether they're controlled or uncontrolled, regular or irregular controlled. Okay, what's important is check the values. Two values you need to check. One is the random blood sugar, RBS, should be below 180 for you to do any interventions, number one. Second is you check for their glycated hemoglobin. If the glycated hemoglobin is below 7, then they're absolutely good enough. So you do a glycated hemoglobin and then you do a random blood sugar. If both of them are within normal ranges, that is with below 7 and below 180, you're good enough to go out and do any treatment. But yes, you put them on antibiotics. You schedule them well, see that they're well rested when they come for their interventions. See that most of the interventions that you do are less traumatic. It doesn't mean you shouldn't do aggressive procedures. It doesn't mean that you don't do an implant or anything. You can do an implant, you do a full mouth perio surgery, you do a grafting, GTR, everything. But see that you handle the tissues well, very gentle. Okay, and that's how you treat these patients. Some of the things important are you have to understand is post-operative recalls for diabetic patients have to be very, very frequent, because we know now that periodontal disease influences diabetic status and vice versa. So because of that very reason, because of the movement of sugar levels will influence the periodontal disease activity, and presence of periodontal disease activity influences your sugar levels. You need to see that both of them are very well controlled. So you need to treat periodontal disease. Treatment of periodontal disease is a very important factor in treating diabetes. So someone who's got diabetes, then you go ahead and see to it that they're treated for periodontal disease. Okay, it's very, very important factor. So once you're done with that, then you should be good enough. So you put these patients on a pre-medication. So if you're scheduling them for a surgery on Monday morning, you ask them to start on medication on Sunday morning. So Sunday morning, Sunday night, and on Monday morning, they take an antibiotic and then they come to your practice. So what you do is you cover them up for any kind of an infection they can develop. Apart from that is thyroid. Thyroid is again a very common issue, hypothyroid and hypothyroid. Hypothyroid patients usually are low on response, so you need to literally tap them to respond. They're usually taking medication like thyroxine, but yes, you need to check. See that you don't put them on anything that would depress them down, so you don't give them any alprazolam, etc. On the other hand, patients who have hyperthyroid, the most important thing you need to check is hypertension in them. Hyperthyroid is directly related to hypertension. Avoid aggressive therapies in these patients. Okay, and this is the only class of patients in whom you don't use adrenaline in the local anesthetic. So if you want to do procedures, do a short procedure and see that you don't use adrenaline in the local anesthetic in these hyperthyroid patients, no adrenaline. Parathyroid, again, a hormone released from the parathyroid glands releases something that controls what we call is calcium and phosphate balance, and that's why it influences the bone, and that's how it influences everything in the periodontal tissues. Okay, the best part is patients know that they have a parathyroid deficiency. Usually it is secondary to a thyroid surgery. Okay, someone having parathyroid freestanding parathyroid deficiencies are very, very less or non-existent. It's usually secondary to thyroid surgery, and that's why you just need to keep a check, take the history. If someone says they have undergone a thyroid surgery, then you get their calcium and phosphate levels done, and then you should be good enough to go by adding the prescription. If not, if you're in doubt, always send back to an endocrinologist and they will do the needful for you. Okay. Last but not the least, very important is adrenal glands. And why is it important? Anyone who's on steroids, anyone who's undergone an organ transplant, etc., or someone who's on autoimmune disorders, even for conditions like psoriasis, these are those patients who would be having something called a HPA axis suppression, that is hypothalamo-pituitary adrenal axis suppression, because they're already on steroids. The body's own adrenal glands are not producing adequate amount of steroids. So what I would say, if you have to treat, there's nothing wrong in treating them. Number one, see that you are again covered with good antibiotics so that they don't develop any secondary infection. Second, see that whatever medications have to be given, let them take them, but you double the dose of the steroid or even triple the dose of steroid. So someone is taking 20 milligrams of prednisolone, you ask them to take 60 and then you start treating them, so that the surgical stress or operative stress does not cause any depression of the HPA axis. So that's important. So you double dose them or triple dose them and then you can procedure. So if you don't want to do that on your own, you can always ask the endocrinologist to give you opinion on what's to be done. One of the most important medications, though I have not listed here, is patients on anticoagulants. Okay, anticoagulants are those class of drugs which a lot of patients take. Most of the people above 40, 45 years of age, even if they don't have any heart issues, they take anticoagulants. And what are those anticoagulants? It can be aspirin, it can be clopidogrel. Okay, and some of them even take what we call as if they're undergoing what you call dialysis, then they're taking warfarin. Okay, so or heparin. So now when we have these patients, we have to understand that they form a huge chunk of the patients who come into our clinics. So you always take a very good history. Case history recording of these patients is paramount. Okay, so literally list down everything what the patient says. That's important. The easiest and the best way to save yourself and save your patient is to take the proper history and jot down everything. Okay, if you take the history properly, then it's very easy to manage, and that's what is important. Okay, so when we start looking at patients for treatment of periodontal disease, etc., who are medically compromised, very important is do a psychological analysis. What it means by psychological analysis? Very simple. Check how stable they are, how cooperative they are, when they want to come, when they don't want to come, what are they fussy about. Record that first. Second, check what they need and what they want. There are times you don't need to do certain interventions. So as long as it's not causing an infection, etc., it's not causing a major disorder in eating, functionality or anything, don't do certain disorders, certain interventions. Okay, and then check what you need to do if the patient is concerned about aesthetics, mastication, phonetics, etc. So depending upon that, you do your clinical interventions. Smokers, I think it's a separate chapter altogether. We will leave it for that. Key, what's important? Now, which patient you would undergo a periodontal therapy? And that would be anyone you think is fit enough to undergo open extraction, is fit to undergo surgery. So what we do in clinics is something called as a safe surgery protocol. What is a safe surgery protocol? Is this: produce to keep these patients in your practice, undergoing all the treatments, paying you all your bills, but very safely. So that is called a safe surgery. So what you do, you schedule them comfortably. Morning appointments. Morning is not 6 o'clock, but you call them at around 11:30 when they're well rested. Patient looks under stress, you can always pre-medicate them with an alprazolam 0.25 mg and a Valium 5 mg. See that your operatory is always set up. Okay, so when the patient walks in, you don't need to move around a lot of equipment, you don't need to make a lot of noise in your clinic, so create a lot less hoopla around your clinics, what we call them. Be very gentle while handling the patient, speak to them nicely, be very cordial in their behavior, and very importantly, collect your fee before you start the treatment. Always observe the change. Always, so even when you're, because we are going to treat patients under local anesthetic, you can speak to the patient and keep on checking how they're doing. Okay, ask a patient to raise their left hand, right leg, etc. when you're doing, so you'll come to know that how well they're responding to the treatment, and whether they're comfortable on the chair, whether they can hear your instructions. Okay, always, if you think there is something not good, always identify the change, see that you take proper insurance. Proper consent has to be always taken, and an emergency kit is an absolute requirement. Okay, so always important things in the emergency kit would be a hydrocortisone, Avil, compose, an ambu bag is necessary. Undergo BLS training, know your local emergency numbers, and always have your friends on call whenever you have faced something like this. So what's important when we look at periodontal management of medically compromised patients? Understand that patients are going to have medical conditions. A lot of our patients are going to have medical conditions, and because they're going to have medical conditions, it doesn't mean they are denied of dental or periodontal care. You need to give them the entire gamut of periodontal care. Okay, whether it's scaling, root planing, polishing, extractions, whether it of bad teeth and replacement of implants, everything comes under the gamut of periodontal care. So irrespective of the medical condition, you should be able to give them every treatment, but see that you do it very carefully and following all the surgical and post-operative protocols. Okay, I think with this, we will close this chapter. If anything is there, I am available. You can please contact me at any point. Thank you so much, everyone. So I'll just stop this recording and then I will just put it on the site.